Next speaker is Dr. Tom Noffsinger, Twin Forks Clinic, Nebraska. Tom was raised on a ranch in eastern Colorado and incidentally is still involved in ranching. He attended Colorado State, received his DVM. He's a member of the Academy of Veterinary Consultants, AABP, ABMA, and the Nebraska Veterinary Medical Association. A couple of nice awards, Consultant of the Year from the Academy, and the Nebraska Veterinary Medical Association Distinguished Service Award. Tom is probably better known for his work, his numerous presentations, demonstrations on better, less stressful ways of handling cattle, and thus he's been dubbed the gentle doctor, and those of us who know him certainly agree with that title. Tom?
Thank you, Dr. Robert. I really appreciate this opportunity to share with you in the next few minutes. I want to start by acknowledging where the information that I'm going to present comes from, and I want to recognize really important mentors in my life, people like Dr. Robert Pearson at Colorado State, my veterinary partners in PAC, my partners in Geisler Technologies, and then most of all the caregivers, the feedlot people working out there every day. It's really important that we understand that what I'm going to talk about comes from actual production settings. But Whisper is a result. I'd like to kind of share with you and review what inspired us to even think about a little different diagnostic approach, why we were inspired to do that, and then share with you evidence that it was needed, explain to you what Whisper technology is, and then show you the status quo of where we are with use in this technology today. The point is, the more we know about our patients, the more we know about our environment, the more chance we have for success. So I think whether we're talking about communication or therapy or economics, building understanding, building information about whatever we're working with is really important. So what we're seeing is that Whisper is an audio technology that allows us to see. My dream when we started with this was that if I could have a fiber optic camera that would view the outside of the lung, and I could correlate depression, appetite, and temperature with that view of the outside of the lung, that we would learn quickly. And what my caregivers have proven to me is if we wait until we have external gross pathology on the surface of the lung, we're already too late, maybe a week late. So we need to look for technologies that find histopathological changes. We need to look for technologies that absolutely identify a need for therapy prior to significant disease. And it's just so exciting to see some of these changes. These Dr. Q pointed out yesterday that our goal is to have Dr. Pearson and this man be the Rock of Gibraltar when it comes to changing medicine. How many of you know who this is? I didn't. This is René Laennec. He's a French physician, and he's a little older. Well, he's not here now, but he in 1816 he changed medicine. What he did was invent a pretty simple tool. Prior to this instrument, medical physicians use subjective observation of symptoms, presence of fever, and postmortems to do diagnoses. And that kind of, I don't know. But as he refined this invention, what he transformed medical activities, visits to a hospital, visits to a feedlot hospital, from an observation, a collection of a fever, to an actual examination. And as he listened to these people, whether it be their chest, their abdomen, he was able to correlate some of the things he saw on the street, some of the things we see in a feedlot, to actual pathology. So I really think it's important that we understand, as we've listened to the history of BRD management and therapy in the last 50 years in our businesses, it's pretty clear that if we keep doing what we've always done, there's a high chance that we're going to get what we've always got. And so I think we need to think about that a little bit. These studies we're all aware of. The main thing I want you to pull from this is that BRD is important in our beef production systems, and that we've had some big improvements in vaccines and adjuvants and antibiotics. And you could see from a lot of the data presented this morning, some of these issues continue to be really important in our operations. Those numbers are outdated, but if we compare the values of animals today, in Dr. Fulton's study, it's amazing how important it is that we keep reviewing and watching for signs of progress. This is the most discouraging thing to me is the work of Dr. Lonnie Bryant and Dee Griffin and all of us that have tried to measure the correlation between a treatment tag and a lung lesion at harvest. I just think that could be fairly disgraceful. So we have, that 2006 study, 42% of the cattle harvested from that lot had lung lesions at slaughter, and 70% of those cattle that had lung lesions had no treatment history. So it tells you a lot about the behavior and the instincts of these animals. It's only been since I've met people like Bud Williams and some of those mentors that I understood that cattle are the biggest liars in the animal kingdom. And when you see a set of calves come to Kansas from Arkansas and they trot down off that truck trying to evaluate their need for metaphylaxis, trying to evaluate their situation when it comes to respiratory anatomy and function is ridiculous. Is ridiculous. Because their main goal is to prove to you that I'm okay, I'm okay, I'm okay. And so it's really, really important that we understand those instincts. This comment from Dr. Bryant's paper published in 1999, I think is still very, very true. And our goal should be to not only improve the correlation between a treatment history and a lung lesion at harvest, but to be able to make really, really powerful economic decisions based on prudent antibiotic use. I think we finally have stockmen now in some of our practices and some of our ranches that if we teach those animals to take care of each other, if we take the maternal behavior, the weaning, the new two-phase weaning things, all of these stockmanship, all of these types of things that are coming forward, that we should be able to integrate relationships with animals and people through the system to where we can build correlations between treatment history and harvesting. This is what we've always designed our treatment protocols from. Depression. Respiratory disease can cause depression, so can fatigue, so can dehydration, anxiety, lameness. There's huge amounts of other sources of depression. It's absolutely right. Appetite. Sick cattle don't eat, but some animals do not eat because they've been without food for 18 hours and their rumen pH has gone up and it's not down. Dr. Kev taught me in Australia that if that rumen pH goes up, there's no prayer to get him to eat until you acidify the rumen. Now, it's hard to talk feedlot veterinarians into acidifying the rumen, but it's huge, absolutely huge. Respiratory nature is really important, but all of us know how dynamic that system is within cattle and how an interstitial pneumonia breathes differently than a BRD, than an acidotic animal, than a dehydrated animal. So looking at the respiratory nature and respiration rate is a tool, but it's not conclusive to BRD. Temperature, probably when I started thinking about this is that I noticed when I designed my treatment protocols based on a temperature ceiling, and I said, my pen writer, you cannot treat an animal until his fever gets to 104. My best crews always knew if that animal was intolerant to exercise and the thermometer only said 103.8, thank God they put 104.2 in the computer and treated him. And so I think we've all been there. So this animal is not uncommon. This is an animal with 5 days on feed, and he meets all the DART deals. He's depressed. He didn't have any appetite in his pen. We walked him around that pen, and he passed little rabbit turds. No hydration, a little bit of a soreness in that right hind. But when we took him out of a place he hated, he ate 20 pounds on the way to the hospital. By the time we got to the hospital, he wasn't depressed. He was starting to fill, and so it would have been a mistake to treat him for respiratory disease. The point is, we've got all kinds of evidence this morning that clinical ID of BRD is not proven accurate, and we need to keep working harder on that. Very, very subjective things that we've used to justify anti-infective use or therapies or metaphylaxis. So just real quickly, those are the first two animals I purchased. I could have a ranch now if I hadn't bought all these cattle. But anyway, this little red steer had a temp of 106, the white calf 5.5. Both had clinical depression scores of 3. Both needed to be in the hospital. But the red calf was a lung score 1. The white calf was a lung score 4 or 5. So I elected to euthanize this poor creature, and that's what the gross pathology looked like in that animal. In contrast, the little white calf had a temp of 55 and a lung score 4 or 5. Her lung was different. The gross pathology in that lung was different. The question is, here are two similar animals clinically, and the point is, this allowed us to study whether they need the same antibiotic treatment, or the prognosis is the same, and most of all, how long would it take an animal the lung on the left to go to the right? We used to think that was a several-day process. With some of our experimental challenge model, that can happen in less than 11 hours. And so if you miss him on Monday, you're in trouble on Tuesday afternoon. So it's really important that we can measure that and send information of that back to a pen writer. So we taught people to use stethoscopes manually. This is just a summary of manual auscultation and case fatality rate by lung score 1. The purples are 1 and 2, 3 and 4 and 5. But that's what encouraged us to continue to try to give our caregivers information based on case definition, because it changed the way they predicted outcome. The cattle are so beautiful when it comes to a stethoscope. When we first started doing this, I wondered why when I listened to a thoroughbred horse at rest, I heard nothing, but I could go listen to an 800-pound steer and it sounded like a rock band in there. Simple. The oxygen requirement for these two animals is basically huge. Look, the horse and the ox oxygen requirement per kilogram of body weight is huge. That cow needs that much oxygen per minute, the horse, and then you all know about the discrepancy between the lung volume of those two species. The Creator built this animal that needed a lot of oxygen. It must have been on Saturday and forgot to give him a lung. So the flow rates between these two species are very, very different. The flow rate, pulmonary millimeters per minute, 8.7 for cattle, 1.5 for a horse. So it's amazing. And this leads us to a huge opportunity to listen to these animals and create a subjective tool that will create a situation where we can base treatment and prognosis on more than a subjective undifferentiated fever or depression score. So what Whisper is it's been about an 8 or 10 year project, and we use something like this to collect. You listen to the animal for 8 seconds. It sends it to a computer. We've had to put all kinds of filters in here to take the heart sounds out, to take the bang and crash and other sounds. And this is a dynamic logarithm that has been changed and revised over the past 8 years based on outcome. And so we would examples would be, here's a lung score 1. That's what the audiogram looks like. That's what the histo looks like, and it's an example of the gross pathology. In contrast to a lung score 3, that's what the gross pathology. And this is a really, really amazing to me how significant that histopathology is. I didn't realize, but those red blood cells only have 0.7 of a second to exchange oxygen or exchange carbon dioxide for oxygen. And so if that alveoli changes from being one cell thick to multiple cell thicknesses, the efficiency of respiration is really tough. But those are just examples. Here's a lung score 4, pretty nasty looking deal. Bronchi starting to fill up. But the point is, the outside of, whoops. Oh, come here. Sorry. What amazes me is this technology can find that severe histopathology while the outside of the lung is still pretty normal. We have time to change those animals when we treat them that early. So this is just some statistics on the data. This is 3,000 first-time BRD pulls from one feedlot, one fall season, mostly Tennessee, Kentucky creatures that came to Nebraska. Weather was decent, but essentially when we looked at case fatality rate by thermometer, by temperature, here are the rectal temperatures on initial pulls. Here are the case fatality rates for those categories and the numbers of cattle in each category. Those same animals were lung scored at the same time and classified in a 1 through 10 severity score, which we've reduced now to 1 through 5. But the point is, these same animals, as we went up in severity, there was more correlation to treatment outcome. When we used only the thermometer, correlation was 6%, confidence interval of 2.5 to 9.5. In contrast, we used the stethoscope, 79.8% correlation to outcome, confidence interval there. These are more recent treatments. This is just looking at 15,000 first-time treatments in 8 very variable feed yards. I have 1,399 of those cattle went to heaven for an 8.68% case fatality rate, and the qualifier was that they needed to be above 104.5 to be included in the data set. This is just using the thermometer to predict outcome. The thermometer predicted 57% of the deads. The whisper stethoscope by itself was able to predict 85% of the death loss in the group. And we used the combination of auscultation and the thermometer. It's by far the best. So including both the auscultation and the temperature, we have more power in predicting and prognosticating. So I just want to finish with then how we're using this information on a daily basis. First of all, I think the information we've had today would encourage us that there's some possibility that some of us have treated some cattle that did not have pneumonia. And there's a good possibility that some of us treated some cattle that had severe pneumonia and we treated them so late it didn't make a difference. So I guess our goal would be able to think if we can do better than that. So when we see this little animal that looks like a really, really depressed animal and someone calls and says, what do you think we should do with this animal? Maybe we should ask more than what is his rectal temperature? What does he sound like? What is his tolerance to exercise? So if we have some idea of what the function of the lung is, we might be able to give more information on implementation of our anti-infective programs. And I think it's really important that we listen to what Dr. Apley said, because at some point in time, we may have to have evidence that will justify our use of an anti-infective, more than I think he looked different than his brother. And so I think as we go forward, if we can, what Whisper's done for us at our feed yards has empowered our caregivers. When we have pen riders come and ask, I pulled 7 cattle out of a pen today, Dr. Tom, am I on time? Well, some of them had fever and some of them didn't. What did they sound like, he always says. If you pull 10 cattle out of a pen and they're all lung score 4, you need to get on Old Bay and trot down there and get some more. If you pull 10 cattle on there and they're all lung score 1 or 2s, you're okay. And so what we use is this, all of these sounds are sent up in the cloud or wherever that is, and they come back down here and they tell you how your team's doing on a daily basis. And so when you see changes in that, then you have an option to call and intervene. We could do this by pin, by yard, by pin rider, it's really kind of interesting to watch it on Saturday, Sunday, and Monday. So, at the end, what we're all trying to do is do all we can to enhance our ability to care and provide welfare for these creatures. If an animal comes into the feed yard and half of his lung is already scarred in, probably metaphylaxis is not the best thing for him. Maybe he needs to go back to pasture. If we bring in 100 head of cattle and we know they're at risk, do we treat the sick ones or the well ones? I don't know. It's really important that we use, Okay, so these natural feed yards that we're doing, we all know that we have lots of cattle pulled during the transition time that have rapid respiration and salivation and depression. And if their lungs are not infected, the last thing they need is an anti-infective. So there's lots of places here to have a chance to provide information to people. And absolutely our dream is that this technology, this type of information can help us with our decision-making processes, be more refined in our treatment protocol analysis. One of the things that's really important is that pharmacology must be real, Dr. Mike, because we can treat a lung score 4 with antibiotic A at a feed yard, and we'll get a given response. Or lung score 1s and 2s. We can use that same product on the severe cattle, and that response really is not very impressive. On the other hand, there are antibiotics with the correct pharmacology, volume of distribution, duration that fit the cattle. So it's really, really important, I think, that as veterinarians, as scientists, that we use all the information, all the tools that we have possible for prudent use of our anti-infectives. With that, I appreciate your attention. Thank you very much.